Respected all, good afternoon. I, Dr. Kshitija Singh, Officer in Charge, Patient Quality from Department of Hospital Administration, welcome you all to third webinar of the regional webinar series on patient safety, jointly organized by the Patient Safety and Quality Cell and Department of Transfusion Medicine, AIIMS New Delhi, and World Health Organization, Southeast Asian Regional Office. The theme for today is Hemovigilance in Healthcare, Surveillance, Safety, and Continuous Improvement. In the first half of today, we have had a CME, and now we would be following with the webinar. We have with us our eminent speakers and participants. We have with us Dr. Aparna Singh Shah, Regional Advisor, World Health Organization, Southeast Asian Regional Office. Dr. Nirupam Madan, Medical Superintendent AIIMS New Delhi and Professor, Department of Hospital Administration. Dr. Shruti Narayan, Medical Director of Short and Consultant Hematologist and NHS Blood and Transplant. Dr. Gopal Patidar Sir, Additional Professor, Department of Transfusion Medicine, AIIMS New Delhi. Dr. Kshitija Mittal, Assistant Professor, Department of Transfusion Medicine, Government Medical College and Hospital, Chandigarh. Dr. Hem Pandey Sir, Additional Professor and Head, Department of Transfusion Medicine, AIIMS New Delhi. Dr. Rahul Chaurasia Sir, MD, DNB Transfusion Medicine and Additional Professor, Department of Transfusion Medicine at AIIMS New Delhi. Dr. Satyam Arora, Additional Professor, Department of Transfusion Medicine, Postgraduate Institute of Child Health, Noida, UP. And Dr. Nishant Sharma, Assistant Professor, Department of Hospital Administration, AIIMS New Delhi. Some of our speakers would be joining us online, and some of us are here present with us. To start with this, I would first request Dr. Aparna Singh Shah to talk on hemovigilance in healthcare, surveillance, safety, and continuous improvement. Ma'am has a vast experience. She is presently a regional advisor of blood safety and transplantation, infection prevention and control, patient safety, quality of care, Department of Health System Development and UHC, World Health Organization. Extensive experience in infection prevention and control, patient safety, hemovigilance and quality. Ma'am has been actively involved in capacity building and training of healthcare professionals. Ma'am has contributed to policy development and implementation of national quality standards and a strong advocate for patient-centered and safe healthcare delivery. She is also engaged in research and academic activities in healthcare management. We welcome you, ma'am, and request you to please take over for the introduction on hemovigilance in healthcare, surveillance, safety, and continuous improvement.
Thank you, Dr. Kshitija. So, good afternoon, colleagues, friends. First of all, I would like to thank All India Institute of Medical Sciences for organizing this very important webinar series. With your permission, I would like to switch off the video so that I can present, and I would like to request Kshitija to project my slides, please.
Ma'am, you may start. Can you see the screen?
I see the slides actually. Thank you. So, WHO folks CPG for more than 5 decades. Transfusion services, including hemovigilance, to ensure safer transfusions, better quality of care, and improved patient outcomes. Next slide, please. This slide, next. Uh, 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 Hello. Continue.
Ma'am, there's some internet. Is your internet strength good, ma'am? Because while you sure, sure, ma'am. We can do that. Yeah. Apologies for the technical glitch. Ma'am would be reconnecting. She'll disconnect and reconnect. Meanwhile, may I request Dr. Shruti ma'am to kindly, ma'am, can we start with your presentation?
Yeah, that's fine. I can share my screen.
So, ma'am की screen check कर दो. Ma'am खुद कर रही है. So, may I please request Dr. Shruti Narayan ma'am, President, UK SHOT, Serious Hazard of Transfusion, International Hemovigilance Network. She would be talking on basics of hemovigilance.
Thank you, Kshitija. Can you hear me? And you can
Yes,
see my
ma'am.
slides?
Yes, ma'am.
Okay, fantastic. So thank you for the introduction and especially to Gopal for inviting me as well. And I would basically be covering the basics for hemovigilance here. So over the course of the next few minutes, what I want to actually cover is the definition of hemovigilance. What is the historical evolution as well as the development? What are the international and the national hemovigilance programs that are available? And organizational structure, the stakeholders and the contributors for an effective hemovigilance program, but also understand what are the objectives, the scope, and the significance of hemovigilance. Now, starting with the very basic, the fundamental questions of the what, why, when, how. Everybody is familiar with these definitions of the hemovigilance. Essentially, this is like the pharmacovigilance for the medicines. This is a set of surveillance procedures covering the entire blood transfusion chain. And the main thing is, the role and what is actually the rationale for having a hemovigilance system. Ultimately, it is actually about enhancing the transfusion safety. We are learning from our experiences, not necessarily only just failures, but we'll come to that in a minute, but also actually then thinking about what are the improvement actions that we need to take. So just explaining that a bit further, this is actually a simplified figure, which is actually showing the whole journey of blood. So number one, where you're actually then going through the routine of the donor selection as well as the collection of the blood from the donors. There we have the donor hemovigilance, which is focusing at that end, but also you're actually how we are processing and the validation of the blood components and all the changes that happen within the blood. That is also actually coming under the blood safety.
Shruti, just sorry for the interruption. Can you put your slide on the slideshow mode?
Aren't you seeing in the slideshow?
No.
Which one are you seeing at present?
From the first slide also.
You're only still seeing the first slide.
Yeah.
Oh,
Hi, Shruti. If you're using multiple screens, I think that may be because of that.
Yes, I am on multiple screens. So let me share my full screen and then I can actually do that.
Yes.
Apologies.
Yeah.
So there we go.
Now let's see whether that will work. Is that showing you the full slide?
Yes.
And if I move forward, are you able to see the... Okay, now is it moving? Okay, fantastic. So, okay, so I've covered the overview of the session. Apologies, everyone. I think I'm not used to Google Meet, so clearly a lot to learn as well. So here we are. I think the two things that I was mentioning is about what do we want from the hemovigilance and what is hemovigilance. So the first is it is a surveillance procedure, but then the main thing is actually what are we answering about, okay, you've collected the information, what are we doing with that information? How are we actually then making the improvements? And this is actually where I had paused. And this one is actually then showing you the whole cycle of the journey of blood. And you're actually then going through from that donor end where you're having the donor hemovigilance, but you're also actually then having that vigilance continuing through the entire blood supply chain, what is happening in our processing as well as the testing, and also at the recipient end. So more often when we talk of hemovigilance, we may be talking more about the recipient hemovigilance, but it is actually really important to actually then see that it covers, the all aspects of the journey of blood. And the challenge for us is actually how do we have that visibility within our hemovigilance reports about the aspects that are actually covering there. But remember, the important thing that I mentioned is about what are we doing with it. It is not data collection for data collection's sake. It is what are we actually gathering? How are we gathering the insights from this and influencing safety? And when we look back, the 30 years of hemovigilance, how efforts were really born out of curiosity. The questions being asked about what are the gaps in practice, what can be done better, and it is actually driven by a commitment to improve and a courage to explore. So it was early 70s and the 80s where across the world in different countries, there were reports of these viral transfusion transmitted infections. There were also ABO incompatible transfusions, which otherwise should be completely preventable. And they started actually providing the impetus for the safety measures, including the hemovigilance. And then we see in the early 1990s is when the hemovigilance systems began being established in various countries. So, within the first 5 years, we are actually then seeing France, Japan, Germany, Greece, UK, they were all actually then beginning the semblance of a hemovigilance system. And in 1995, in the 5th Regional Congress of the ISVT, so you can see going back several years, hemovigilance procedures in transfusion medicine figured as one of the key topics that was actually being discovered. And the first formal European hemovigilance seminar was actually held in France, which then paved the foundations for a European hemovigilance network. And subsequently, you can see how the hemovigilance systems began being expanded. There are actually lots of the countries which were actually then talking and establishing. The examples are provided here, like Ireland, Brazil, and Canada started actually then establishing between 1999 and 2005. And increasingly, people were actually then beginning to recognize the importance. So there were regulatory frameworks and legal frameworks being actually then established. And here are, you can see in the 2000s, you can see how this is actually then expanding. But also in the EU, they became enshrined in the law as the EU directives, which in the UK actually were also transcribed onto the blood safety quality regulations. And formally, the EHN from the European format, it then moved to being called as the International Hemovigilance Network in 2009. And subsequently, we are actually then also seeing the further development. Like in India, you've actually then had the the hemovigilance system set up. But also in 2012, there was a strategic review for the IHN as well. And I would direct you people to that article as well, the 30 years of hemovigilance, which actually then covers all of it. So you can see how the IHN as an organization also started actually then growing. But equally, you can also see how that ripple effect where all the countries came on. And in the 2020s, we are actually seeing global developments. Now, although we do know from the 2018 survey, it is only 51% of the countries have a hemovigilance system, but we know in the recent few years, there has been that expansion and improved maturity of the hemovigilance programs. So I think that is where there are still some regional differences, but there are still challenges. All of us are on a journey, and it is actually how can we share the learning and how do we actually then improve and put things in place. So this is actually just a snapshot of the timeline of how hemovigilance have actually then improved. But the important thing that we need to take a step back and actually look at it is remember blood transfusions are biological therapies.
Now, they definitely save and improve lives, but with any medical intervention, like any other, the blood transfusions also carry risk. So therefore, a question that we are asking is, how do we have that finger on the pulse? How do we actually then have that transparency that we can actually learn from these reported incidents? And that is where the hemovigilance systems play a key role in enhancing that. But the other important thing is, what are the other benefits of having a hemovigilance system? Yes, we say it helps monitor the transfusion safety. It also has that transparency and also helps build the trust in our processes. But what it is also telling us is it is helping identify the risk factors. So what you may be able to learn from a single case in a hospital, you can see at the national level what are actually the common themes that are coming through. That then facilitates the development of risk mitigation actions. So when we look back to Charlie, that was what happened. So because the early signals were actually then saying that it is more common when patients are actually receiving the plasma, which is actually predominantly from female donors. That then raised the question, is there an immunological basis? And then you can actually see how the donor selection guidelines were actually then altered so that you're focusing on HLA testing for the female donors, and it is predominantly male donors that were actually then selected for the plasma and the platelets. So you can actually see how that has impacted, and we saw a reduction in that immunological TRALI as well. So you can see through the hemovigilance report, because it's a continuous cyclical event, you can then also note the impact of these interventions. Now, we still have a way to go so that we are actually comparing apples to apples, because I think benchmarking the challenges, even though we may be working to the same standard definitions, how that is applied in practice and how that is reported, even the denominator data is quite variable between the hemovigilance system. But like that, PDSA cycle, it is that continuous. How are we evolving? How are we improving our systems and processes? Now, when we look at, who are all involved in this? Hemovigilance is everyone's responsibility. It is a collective effort. It is a shared responsibility. And it only works when we all work together. So you can see the journey of blood, and you can actually then also see the different professional groups who are actually then involved. So even within the clinic, in the hospitals, the clinical areas and the laboratories. But also the hospitals need to work well with the blood establishments and the blood services, but equally the ministries of health or the Department of Health that you're actually having. And within the hospital, you're not just talking of the people who are involved in hemovigilance. Often they are actually then part of that transfusion teams and with other activities. But how are you building it with the quality, the safety teams, and the governance teams? But we need to really be working with the patients, with the blood donors, and the community organizations as well. And internationally, we have several organizations which would be actually supporting. Like in France, you have a statutory reporting. But the main thing everybody is really clear is that you should be going towards a non-punitive culture. You should move away from having any kind of a disciplinary impact when somebody is reporting an incident. Okay, so that is really important to have that just learning culture. But the other thing is, again, different systems may have anonymized data, like SHOT has completely anonymized data, whereas you may have a system where you're able to identify and then which may also facilitate different set of actions. The other thing is, again, you may have a system where anything and everything that goes wrong with the transfusion is actually collected, which is comprehensive, whereas depending on your capacity, you may be able to then choose that we start collecting with a certain categories and then build over time. So, it is about having a system that works and then evolve over time rather than having one which is actually then set to fail. And important question that we also ask is, okay, you have a hemovigilance system, but how do I assess? And there are different types of quantitative and qualitative metrics that you can actually then use. So these are some of them. This is not an exhaustive list, but you can actually then see from a quantitative one, what are the number of reports? What is the trend in the number of reports? And the most serious complications, number of the deaths, the major morbidity, the number of the transfusion transmitted infections. Equally important is that proactively, how are we actually then, capturing those incidents where the safeguards in place have worked? So, how are the near misses being actually captured? But also, what is the impact? So from your blood establishments, if there have been any changes, so like historically, we are able to then show with leukodepletion, what has been the change? With any kind of irradiation of the blood products, what are we seeing with say, transfusion-associated graft versus host disease? So you're able to see whatever changes you've made in your blood processing, how are you actually then influencing the transfusion reactions? Also, you can actually have the parameter about the timeliness and completion of the reports. How regularly are the reports being actually submitted soon after an incident happens? But moving towards the compass is, we should not always spend the time looking at the rearview mirror. So we need to actually then be seeing about a holistic approach to safety. How can we, and near misses is actually helping us, but equally, how can we learn? And especially the experiences from short, what we realize is the same factors that we are seeing in the incidents, that is also going well in our excellence as well. So what is it that we actually have that is working differently for those instances? And how can we replicate that? So how do we actually then have that holistic approach, learning from day-to-day events, but also learning from excellence? But equally, we may teach our staff clinical and laboratory technical skills, but how are we actually then providing them the principles of patient safety? The human factors principles, the just culture, the leadership, how are we actually getting them to work together as teams? So, it's really important for us to embed that safety culture of that just learning culture. But equally, we know that with transfusion, there are lots of IT that we are talking about, and IT supports safe transfusion. So how, to what extent is that IT integrated and the interoperability? And also awareness of the human factors principles, the opportunities. So there are different ways, and I would say don't focus on only some of the quantitative metrics. We need to be actually looking at that picture with the quantitative as well as the qualitative indicators. And so the question you may have is, have we seen anything? What has been the change having a hemovigilance program? Now, this year we're celebrating 30 years of SHOT. So this came into existence in the 1996. And now I have some examples of some of the graphs that we have actually then shown. First, when you talk about ABO red cell transfusions now, in the early 1990s, we used to have across UK maybe 30s, 35 to 40, but you can see that reduction, it is more in the single digits now. When we look at transfusion transmitted infection, this is specifically the bacterial transfusion transmitted. We have not had one since 2015. And so the measures in place, the variety of the measures, and I won't be listing all of them, but it's there on the SHOT website. But it is that having that assurance that this is actually working. Also, with respect to the different blood component changes that are there, reducing the exposure to the plasma, leukodepletion, etc., you can see the incidence of the post-transfusion purpura has actually come down. And TAG-VHD, we have not thankfully had one since 2012. And these are all really good news stories. Similarly, the immunological trial cases as well, as I mentioned, the donor criteria that was actually then altered in 2003, and you can see that reduction as well. So, this is actually the richness of having a hemovigilance program, that you're able to actually monitor that. But it is also actually then highlighting other issues. So we have seen increase in the delays, the transfusion delays, and the deaths that are actually being reported due to these preventable factors. We are seeing an increase in the pulmonary complications. And in general, we have been actually noticing that more than 80% of our reports are due to preventable errors. We are also highlighting what are the patients who are actually at greater risk. Now, here in the UK, the way the healthcare system is actually established, you may have some specialized centers where transplants or hemoglobinopathy patients may be actually then cared for. But then for the irregular care, they may be in more local hospitals. But no two hospitals and IT systems speak to each other. And then we see, again, the communications may fall down. So the patients on the shared care pathway, which is particularly disproportionately affecting the patients who are having hemoglobin disorders, sickle and thalassemia, transplant recipients. We also see other vulnerable groups, such as the extremes of age. So, elderly who are having multiple comorbidities, but also neonates and the children where you're having the prescribing issues. We see the pediatric patients being overrepresented in certain categories, like under transfusion, over transfusion, and FAHAR complications as well. And one of the things that we have been learning is we really need to focus on safe systems and processes. There are several systemic issues, as I've mentioned, that with respect to resources, staffing issues, mismatch to the workload, IT, safety culture, leadership. And that is really telling us that transfusion is kind of opening up our eyes towards the deeper underlying issues. But the other thing is, although we have reduced the risk of transfusion transmitted infections, one thing we realize is that that threat will always be there. How can we improve our tests? How can we actually reduce that window period detection as well? But also, there are newer threats that are actually then coming in the horizon. We have had the COVID, we have also had the instances of the monkeypox, and therefore being always constantly vigilant, do the horizon scanning, be always actually then looking for room for new tests as well is really important. And therefore, that hemovigilance is forever a necessity. And the last couple of minutes, I just wanted to say that ensuring safety is completely in our hands. To what extent we are actually asking that. As I mentioned, hemovigilance was born out of that curiosity. trying to understand what is it that our reports are actually telling us and look beyond what is actually then given just in that report. And so you have several organizations, several resources that are actually being produced. Now you have all those provided by the WHO, but there's also the Notify library, which I've not yet included on this slide. But again, that is actually from the WHO and the CNS from Italy. We have ISBT, again from the Hemovigilance Working Party, for which Gopal is actually the chair, and you have several resources being provided there. Again, IHN is more a membership of the systems, and we have hemovigilance reports, publications, and through other collaborative projects, how are we actually developing and supporting the hemovigilance activities, and AABB. And there are other organizations. You may have individual hemovigilance reports, but also individual organizations like SHOT, TRIP, etc., who would also be actually then providing various resources. And when we did a survey, before we did our stepwise implementation guideline, from that digital survey in 2020, the 3 top most common causes for implementation, what are the barriers for implementation are: 1, financial constraints, or lack of trained professional personnel, or failure to identify, engage with all the key stakeholders, and equally people not really recognizing the importance of a hemovigilance. And so how can we as a community support each other and actually then ensure or embed that importance of hemovigilance to all? But equally, there are lots of opportunities and challenges as well. So even for those who have actually have a hemovigilance system and are improving, you can see how there is richness of the data, but how do we optimize the learning from that data? So optimizing that learning is really important. AI, how are we actually harnessing the use of AI in different aspects of the hemovigilance as well? And remember, this always needs that clinical oversight as well. And with the new SOHO regulation, that is the substances of human origin, which is actually coming in the Europe, that expansion to the biovigilance, it is about with all the biological products as well, with the tissues, etc., is really important. And we also see many of the older components coming back, like for example, whole blood, or you also have newer components such as cold storage platelets. So we are going to be actually then the hemovigilance is really important to actually see from studies to real life hemovigilance, how are they impacting, and how are we actually then informing the post-release information as well. And we need to continue addressing the existing challenges that are actually then identified from the hemovigilance data. And so one of the things that I leave you with is actually thinking about, from that traditional model of hemovigilance, about just focusing on how many incidents occurred, how many reactions were reported, that numbers. We're only looking at that retrospective aspect. What we really need to be actually thinking through is this is that safety measurement. The questions we're really asking from hemovigilance is, how resilient is your service? What is the spare capacity? What is being evident from the reports that are being submitted? Are the safety margins being eroded? Can the services continue to adapt safely? And that is what the question that we are actually trying to answer. And so, you may be getting the hemovigilance iceberg, that you have the reports, that is the visible number of reactions, errors, incident reports. But what we are really looking at is delving deeper into these reports and trying to actually see what is coming through at a national level, at a regional level, at a hospital level. What is the staffing levels, the vacancy rates, the staff fatigue, the training compliance, and etc., all of those different factors. And therefore, what I would urge you to think is, every hemovigilance report has 2 stories. First is the events that occurred, but more importantly, what are the safety signals that they reveal? And therefore, our responsibility as the hemovigilance teams is not merely to count the incidents, but to understand what is it actually really telling us about that health, resilience, and capacity. And therefore, an event is not always a disaster, but not reporting one could be, and not learning from one is equally bad. And this is a quote from the former president of the AABB, but this is actually essentially telling us how what we see in the hemovigilance is actually just another focus on the healthcare system as a whole. So if you're having a hospital with higher number of transfusion safety incidents, highly likely that this is actually emblematic of the deeper safety challenges as well. So safety is paramount, and what can we do and how we can work together to actually then optimize the safety. So thank you.
Thank you so much, ma'am, for taking us through the importance, impact, opportunities, and challenges, and dwelling in detail on hemovigilance. And I would request all the participants to please drop the questions that you want to ask in the comment box, and at the end of the session, we can take the questions. I would now request our next speaker. May I once request Aparna ma'am, is the glitch resolved?
I'm not sure, Kshitija, can you hear me now?
Yes, ma'am. You clear and you
So
audible.
I will not switch on my video. I'll just, switch on my audio, and if you can project my slides,
Sure, ma'am.
I can, quickly go through my. Yeah, this is good. Okay. So, WHO has been at the forefront of advancing blood safety for more than 5 decades. In this presentation, I will highlight WHO's leadership and technical support to member states in strengthening national blood transfusion services, including hemovigilance, to ensure safer transfusions, better quality of care, and improve patient outcome. So the slide which you are seeing now illustrates WHO's long-standing leadership in advancing global blood safety over the past 5 decades. WHO recognized the importance of safe blood as early as 1975, when the World Health Assembly adopted WHA 28.72, urging member states to establish well-organized, coordinated, and sustainable national blood programs in response to growing concerns about blood safety and commercialization of blood collections. To support evidence-based decision making, WHO established global database of blood safety GDBS in 1998, which remains the only global mechanism for monitoring blood availability, accessibility, quality, and safety. Recognizing the critical role of voluntary blood donations, World Health Day 2000 adopted the theme Blood Saves Lives, bringing blood safety to the forefront of global public health agenda. A major milestone followed in 2005 with WHA 58.13, which recognized voluntary non-remunerated blood donations as the cornerstone of a safe and sufficient national blood supply, and established World Blood Donor Day, celebrated every year on 14th June. Subsequently, in WHA 63.12 in 2010, further strengthened the global commitment by emphasizing the availability, safety, quality of blood components, and plasma-derived medicinal products, while encouraging countries to achieve self-sufficiency through regular voluntary donations. These resolutions you're seeing on the screen laid the foundation for subsequent WHO initiatives, including Global Action Framework on Blood Products 2026-2030, and their integration within broader WHO priorities such as universal health coverage, patient safety, infection prevention and control, maternal and child health, emergency preparedness, and health system strengthening. Together, they demonstrate WHO's sustained commitment to ensuring equitable access to safe blood and blood products worldwide. Next slide. So this slide highlights the WHO Global Patient Safety Action Plan 21-2030, which is organized around 7 strategic objectives and 35 strategic actions. So on the screen, you can see action 3.4, which is dedicated to blood safety. Next slide, please. Yes. The latest WHO Action Framework to Advance Universal Access to Safe Blood provides the global roadmap for strengthening national blood system over the next 5 years. The framework is organized around 7 strategic objectives covering governance, regulations, equitable access, patient blood management, surveillance, preparedness, and partnership. Today, I would particularly like to highlight strategic objective 5, which focuses on establishing effective surveillance, hemovigilance system supported by comprehensive and accurate data collection, evaluation, risk reduction, and communication. This objective reinforces the importance of using data to detect, analyze, learn from and prevent adverse transfusion events, ultimately improving safety and quality of blood transfusion services. Next slide, please. So, this WHO guidance support member states in establishing and strengthening national hemovigilance system across the entire transfusion chain. Next slide, please. All the reports and the reviews indicate that we have made a good progress, but there is still more to be done. Next slide. WHO has been providing comprehensive support to member states to strengthen national blood system across Southeast Asia region. Hemovigilance is only one pillar of blood safety. WHO supports countries in strengthening the entire vein-to-vein transfusion system through governance, quality, partnership, surveillance, donor program, evidence generation, and innovation, ensuring safe blood, safer patients, and better care. Next slide. So every donation is a gift. Every transfusion must be safe. Through hemovigilance, we transform experience into evidence, evidence into action, action into safer care, advancing patient safety, improving quality of care, and striving for zero avoidable harm. So thank you.
Thank you so much, ma'am. So, those of you who joined us late, we had started with the introduction, basics of hemovigilance, and now moving on to our next speaker. Our next speaker is Dr. Gopal Patidar, Additional Professor, Department of Transfusion Medicine, AIIMS, New Delhi. Sir has been awarded with Dr. Harold Gunson Fellowship by ISBT at Taiwan, Award of Excellence 45th Virtual Annual National Conference of ISBTI 2020, and as Young Scientist Award 9th TransMedCon 2021 by ISTM. Sir has various international involvements as board member, International Hemovigilance Network, chairperson of Hemovigilance Working Party of ISBT, member of International Collaborations for Transfusion Medicine Guidelines, and has national involvements as chairperson of ISTM SIG on TTI and NAT, subject expert for National Donor Hemovigilance Program. Sir has more than 70 publications in his kitty, and today he would be talking about recipients' hemovigilance.
Thank you, Dr. Kshitija, for the kind introductions. So today I will present about the recipient hemovigilance symptomatic approach. It means whenever the symptoms develop after the blood transfusion, how we can approach to the diagnosis of any of the adverse transfusion reactions. So what is adverse transfusion reactions? Adverse transfusion reactions are unintended and harmful responses that occur during or after the transfusion of blood or blood components. It's usually classified based on the time of the occurrence, severity, and the pathological processes. In the time of the occurrence, it could be acute within 24 hours or delayed more than 24 hours. In severity, it is non-severe, severe, and the life-threatening. And in pathological processes, it's immune or non-immune complications. So, classification of the non-immune hazardous or non-immune adverse transfusion reaction of the transfusion is the acute and delayed, like I mentioned, less than 24 hours, more than 24 hours. Both are divided as immune and non-immune. In acute immune, acute hemolytic transfusion reactions, febrile non-hemolytic transfusion reactions, severe allergic reactions, or TRALI transfusion related acute lung injury. Non-immune are transfusion associated circulatory overload, hypotensive reactions, hypothermia, septic transfusion reactions. Then delayed immune or delayed hemolytic transfusion reactions, transfusion associated graft versus host disease, transfusion associated graft versus host disease, post transfusion purpura, and transfusion related immunomodulations. And non immune delayed transfusion reactions are the iron overload. So, what are the common symptoms which develop after the transfusion reactions? Most commonly, you have seen about the fever, then urticaria rash, hypertension or hypotension, then tachycardia, bradycardia, change in the vitals, then dyspnea and the pain. These are the common symptoms which first appeared just after the transfusion reactions. After that, more severity developed, more symptoms develop, but basic common symptoms initially these are developed. So, I will discuss about how to approach after developing this kind of the symptoms. So, first, how to approach after fever during transfusions. So, whenever there is the fever is the rise in the temperature. So, you have to decide that how much amount of the temperature is rise, more than 1 degree or more than 2 degree. If there is more than 1 degree temperature rise, then you have to see next symptom, is there chills and rigor is present or not. If it is present, then you have to see the next symptom, is the change in the vitals like hypotension is present or not. If there, then you have to see is there any dyspnea, or if there any hematuria, and pain, especially pain at the venipuncture site or abdominal flank area. If these symptoms are developed, then you can diagnose preliminary diagnosis at the suspected acute hemolytic transfusion reactions. Then if there is more than 2 degrees temperature is rise, along with the chills and rigor, then again hypotension and dyspnea, but there is no hematuria and no pain at the vein or flank site, then you can suspect it as septic transfusion reactions. Then again, if there is the 1 degree centigrade temperature rise, along with chills and rigor may be present, may not be present, but there is hypotension and dyspnea. Rise in temperature, hypotension and dyspnea, you can suspect as a TRALI, these reactions. Then if there is only rise in the temperature, may or may not be chills and rigor, but there is no hypotension, no dyspnea, no hematuria, or generalized pain only, not at the venipuncture site or abdominal flank, so then you can suspect as a febrile non-hemolytic transfusion reactions. Like in morning we discussed, this is the diagnosis of exclusion. So there is the no symptoms of the hematuria, there is no symptoms of the severe dyspnea, there is no symptom of the more than 2 degree rise in the temperature, means you can exclude the other reactions and it could be the febrile non-hemolytic transfusion reactions. So this is the overall pictures which I said. Now, how to further progress to it? So, what are the common laboratory workup we do after any kind of the transfusion reactions? At blood center, we have to again re-identify the patient as well as the blood unit identity check. Then visual inspection of the blood unit and post-transfusion samples, blood groupings, pre and post-transfusion samples as well as the blood unit samples, repeat cross-match, direct cum test, indirect cum test, and bacterial culture. This test is the required for the each and every transfusion reaction, because these are the establish the basic diagnosis of the any kind of the transfusion reactions. After that, we have to move forward for the specific test for the any specific transfusion reaction based on our suspension, our suspect. Like we suspected the hemolytic transfusion reactions, then we have to do the complete blood count, then LDH, plasma hemoglobin level, urine hemoglobin, total or unconjugated bilirubin, serum haptoglobin, liver function, and renal function test. If we suspect the septic transfusion reactions, then along with the basic test, we have to go for the blood culture of the post-transfusion patient sample, blood culture of the unit, blood culture of pre-transfusion patient sample, assessment of the donation practices, component preparation practices, and storage area inspection, where the probability of the infection or sepsis in the blood component is for probability, then we have to check all those areas also. If we suspect the febrile non-hemolytic reactions, then as I mentioned, we have to rule out the hemolytic transfusion, we have to rule out the septic transfusion, rule out the patient underlying condition, then we can assess the component preparation practices such as the leukoreduction is over there or not. then we can suspect a febrile transfusion, non-hemolytic transfusion reaction. Now move forward to the next symptom. Most common is the dyspnea. After blood transfusion, if patient have during or after transfusion, there is the dyspnea. So how to diagnose that things? So dyspnea after blood transfusion, it could be at the different time period, less than 6 hours or more, less than 12 hours or 12 to 24 hours. So we have to see that at what time the dyspnea develop in the patient during or after transfusions. So if there is dyspnea after transfusion, after timing, we have to see if there is any bilateral pulmonary edema is there or not. By the X-ray, we can see that in X-ray picture there is pulmonary edema is present or not. If pulmonary edema is present, then we have to see whether left arterial hypertension is present, like with the JVP or the central venous pressure measurement. We can see whether the left arterial pressure is high or not, left arterial hypertension is there or not, that we can assess after that. After that, we have to assess the acute respiratory distress risk factors is present or not in these patients. If factors are present, then we have to see what is the PF ratio of that patient and what is the SpO2. If it is less than 90%, then we have to move forward further. If less than 90% and then mild ARDS before transfusion is present and respiratory status is stable past 12 hours, before transfusion past 12 hours patient is stable and mild ARDS symptoms are there, PF ratio is less than 300, SpO2 is less than 90, we can suspect it as a Trali type 2. But if there is PF ratio is less than 300 and SpO2, but there is no ARDS risk factor in that patients. No ARDS risk factor, but PF ratio is less than SpO2 is less than 90%. Then we have to see whether mild ARDS before transfusion is there or not. If no mild ARDS transfusion, then patient is stable before transfusion, then we can suspect it is a Trali type 1. Then we have to see if patient has bilateral pulmonary edema, patient has left arterial hypertension, symptoms developed within 12 hours, and there is no ARDS risk factor, but there is cardiovascular changes in that patients, like left arterial hypertension or all that kind of things. Then we have to see whether there is fluid overload is there or not in that patient. And then raised BNP. BNP we have to check. If BNP, brain natriuretic protein, is raised, then we can suspect is a transfusion associated circulatory overload. Then if there is no cardiovascular changes, no ARDS risk factor over there, then we have to rule out the other symptoms are there or not. No other symptoms, only dyspnea is there. Evidences of alternative diagnosis we have to check. No alternative diagnosis, patient is underlying condition is not leading to the dyspnea, then we can suspect is a transfusion associated dyspnea, TAD. So by this we can suspect what kind of the transfusion reactions after dyspnea in that patient. Another reason could be the urticaria or anaphylactic reactions. If symptoms develop within 4 hours, dyspnea, after that urticaria, pruritus, hypotension, laryngeal spasm, and symptoms are less than 1 hour immediately developed, then it could be the anaphylaxis reaction. But if it is little bit delayed, it could be the delayed allergic reaction in this patient. So by simplifying these things, we have to check the timing along with these basic symptoms, like pulse rate. If pulse rate is increased, blood pressure is decreased, pulse pressure is normal, temperature is rise, body weight is normal, pulmonary edema is there, no cardiac celerity, no Charley line, no pleural effusion, and BNP or anti-BNP are normal, then it is Trali. If time period is less than 12 hours, pulse rate increased, blood pressure increased, pulse pressure widened, temperature normal, body weight increased, pulmonary edema is there, cardiac celerity is increased, Charley line, pleural effusion, anti-pro-BNP, all are present, then we can suspect TACO. But if more than 24 hours, everything is normal, only dyspnea is the symptom, we can suspect as transfusion associated dyspnea. So this is the overall picture of how we can suspect the Trali, TACO or the TAD over there. What are the ARDS risk factor which I mentioned? Like direct risk factors are pneumonia, aspiration, inhalation injury, pulmonary contusion, pulmonary vasculitis or drowning. Indirect are non-pulmonary sepsis, major trauma, pancreatitis, severe burn, non-cardiogenic shock or drug overdose. So again, what are the TRALI type 1? As per the definition provided, consensus definition provided in 2019, first is there should be no risk factor for the ARDS. Then it should be the acute symptoms, hypoxemia, PF less than 300, SpO2 less than 90%, bilateral pulmonary edema, and no left arterial hypertension. This is the type grade A. Then it should be during or within 6 hours, and there should not be any ARDS risk factor in this. Then we can define it as a TRALI type 1. What is TRALI type 2? There is the ARDS risk factor is over there, present or but not diagnosed. Mild symptoms, PF is 200 to 300, along with the A and B symptoms of the TRALI type 1, like acute symptoms, bilateral pulmonary edema, and the within 6 hours or the there is there, then we can diagnose it as a TRALI type 2. Conditions associated with TRALI are cardiac surgery, end-stage liver disease, postpartum hemorrhage, increased pre-transfusion plasma, interleukin 8, positive fluid balance, current smoker, hematological malignancies. All severe kind of the conditions can lead to the TRALI adverse reactions. Then what is TACO? In this TACO, there is should be the more than one these symptoms are required or occur within 12 hours of the transfusions. In this, respiratory distress should be there, and or along with the pulmonary edema, like physical sign, left atrial finding, crackle, orthopnea, chop, or the radiography show effusion, widened vascular pedicles, labor vessel enlargement, etc. Along with that, one or more symptoms of the cardiovascular system changes like tachycardia, hypertension, JV distension, peripheral edema, or fluid overload symptoms are over there, and the BNP is rise in these patients. So by this we can diagnose it as a TACO. Then what are the risk factors for the TACO? You can memorize it as a CRAP. Cardiac disease with the left arterial hypertension, chronic renal failure in this patient, extreme of the ages, younger pediatric patient or the older patients, or positive fluid balance. These are the more risk for the TACO in this patient. Along with that, if you transfuse very rapidly, very low blood weight of the patient, hypoalbuminemia or hypervolume of the blood transfusions. What are the transfusion associated dyspnea? These are the respiratory distress within 24 hours of the transfusion that does not meet the criteria for the TRALI, TACO or the allergic reaction. Means it is a diagnosis of the exclusion. If you are not diagnosed a TRALI and TACO, you can see as a TAD over here. Then again, what is the imputability for these adverse reactions? How you can correlate with this transfusion and the adverse reactions? Like already initially in morning we also discussed that definite conclusive evidence beyond the reasonable doubt that transfusion cause adverse reactions, probable clearly in favor that transfusion cause adverse reactions, possible evidence is indeterminate that adverse reaction could be caused by a transfusion or other reason, unlikely clearly in favor of the other reason, and excluded the conclusive evidence beyond the reasonable doubt that other reason is the cause of that transfusion reactions. Then finally, in conclusion, how to approach for the any adverse transfusion reactions. From the clinical side, whenever they noted the adverse reactions, they stop the transfusion and document in patient file. Then document in the transfusion reaction reporting form. From there, they should send the transfusion reaction reporting form along with remaining blood batch, post-transfusion sample to the blood center or transfusion medicine department. Then send the post-transfusion sample for the bacterial culture, post-transfusion sample for the CBC, plasma hemoglobin or urine hemoglobin. From the transfusion medicine or blood center side, verify the patient identity and as well as the blood unit identity. Then perform DCT test, perform ICT or antibody screening test, identify the other reason for the transfusion reactions, assess the imputability, inform clinician about the final diagnosis and imputability for further treatment, and report to the National Hemovigilance Program. Thank you so much.
Thank you so much, sir. And may I now request Dr. Kshitija Mittal, Assistant Professor, Department of Transfusion Medicine. Ma'am would be taking us through How to Report in Hemovigilance program. Ma'am has been awarded with Dr. Harold Gunson Fellowship by ISBT at Cancun and Malaysia, J.R. Jolly Award at Transcon 2022, 46th National Conference of ISBTI Bangalore, member of Special Interest Group TTI and NAT of ISTM and ISBT Hemovigilance Working Party. Ma'am is also a member of editorial board of AJTS, reviewer of Work Sanguine's Transfusion Apheresis Science AJTS, assistant editor of 3rd edition 2023 of Transfusion Medicine Technical Manual, NBTC and BTS Division, DGHS, Ministry of Family Health and Family Welfare, Government of India, and ma'am has more than 45 publications in national and international journals. We welcome you here, ma'am.
So thank you so much for the kind introduction. So now, till now, we have discussed about the various transfusion reactions. So how can we classify them? Now my role is how to report. Once you have encountered a transfusion reaction, you have established a diagnosis. Now how to report it to the hemovigilance program. So this has already been discussed about the hemovigilance, and the importance is to improve the patient and product safety. So now I'll directly come to how to report. So this, in the Indian context, I'll be discussing about the Indian context. So it is reported online via Hemovigil software, which was developed indigenously by National Institute of Biologicals using transfusion reaction reporting form. So these are the standard formats. So what is this transfusion reaction reporting form? Is a standard format for all reporters, for all the healthcare professionals, and it has been designed to capture all the crucial clinical as well as the lab information which is required for expert review, and it is submitted online to this. So initially from January 13 to April 30, 26, so this was the hemovigilance data. It was collected through this one page, TRRF version 1.0. However, in this form, it lagged, it had several limitations, as there was no information how this reporting centers, they classified the transfusions, how they came to the conclusion, or they made the causality assessment, as there was no column for the what were the signs and symptoms or the vitals. And in addition, there was no column for the investigations which were being carried out to confirm the diagnosis. So then from May 1, 2016, this transfusion reaction reporting form 2, version 2.0 was launched. It is a comprehensive form. So it has been divided into now 6 subsections. So first section is, it captures the patient details. So in this, it includes the patient demographic details, that is their age, the sex, blood group, and the diagnosis. Now, why is this age and sex is important? Why? These are the asterisks, means the mandatory fields. They need to be filled mandatorily. So why it is important is because this age and sex, they can influence the risk and pattern of various transfusion reactions. For example, it has been, as already discussed, that extremes of ages or in elderly, they are more associated with your circulatory overload reactions, or the children, they are known to have more febrile and allergic reactions as compared to adults. In sex, now the female sex, especially who have a history of pregnancy, the multiparous females, they have a higher risk of aluminization. And the blood group, so it will highlight any ABO incompatibility. So therefore, it will rule out, it will help in establishing your diagnosis of hemolytic transfusion reaction. So this was a study, it was as a meta-analysis which was published in Pediatric Blood Cancer in 2022. Over here, the authors, they compared the incidence of adverse reactions in children and adults, and they found that the children who were transfused with red cells and platelets, they exhibited a higher incidence of reactions than of adults. And the incidence of allergic and FNHDRs, febrile non-hemolytic transfusion reactions, it was found to be significantly higher in children and adults. So here lies the importance of mentioning the age of the patient. So now, what is the importance of clinical diagnosis? It helps to distinguish whether the symptoms, they are so due to transfusion, or it is actually the patient's underlying condition. So by this, it helps us in in supporting our classification and in the imputability assessment of the transfusion. Also, by mentioning the diagnosis, we come to know about the various patient groups which are increased risk for specific reactions. For example, thalassemia patients being repeatedly transfused, they are increased risk of allergic or febrile non-hemolytic transfusion reactions. Patients with renal failure, they are in increased risk of circulatory overload. So, and thus that also helps in facilitating this identification of the disease specific trends, so that development of targeted risk reduction strategies can be done. For example, by analyzing this, that the thalassemia being repeatedly transfused, they are at increased risk of alloimmunization and febrile reactions. So therefore, targeted measures like extended antigen matching blood and leukoreduction blood should be provided to this patient was then introduced. Now the next section comes to the transfusion reaction details. Now this captures the vitals of the patient, what were the vitals pre-transfusion and vitals at the time of transfusion, and the signs and symptoms of the patient experience. So now why this is important, pre-transfusion vitals? Because it helps us to establish what was the baseline clinical status of the patient. So thereby it helps us to distinguish the pre-existing conditions, because if the patient was already febrile and then the blood was transfused, then that fever, it was because of the patient's underlying condition rather than the transfusion. So it helps us to distinguish pre-existing conditions from the transfusion related events. By comparing these pre-transfusion vitals with post-transfusion measurements, we can identify clinically significant changes which will help us in the any suggestive of these adverse transfusion reactions. So further, now by recording all this, by providing objectivity to this, so it helps in accurate classification and the imputability assessment. So this is another study which was published in Sang in 2018. It was a multi-center study which investigated the vital sign changes which occurred in complicated and uncomplicated transfusions. And the authors, they observed that compared to uncomplicated transfusions, the transfusions which were complicated by febrile reactions, they were associated with higher pre-transfusion temperature and pulse rates, and the episodes of TACO, that circulatory overload, were associated with higher pre-transfusion respiration rates compared to uncomplicated transfusion. Thus, the authors, they concluded that the pre-transfusion vital signs are important, yet it has been understudied predictor of vital sign changes during transfusion. So now the importance of post-transfusion vitals is, by comparing it with the pre-transfusion vitals, we can detect changes which are suggestive of various adverse transfusion reactions, and thereby it also helps in grading the severity of the reaction and evaluating patient outcome. So thus, what is the importance of recording this vitals is, it provides objective evidence. For example, if you have mentioned as fever, so if you will mention the pre-transfusion temperature and post-trans and the temperature during transfusion, it will provide an objective evidence for that reaction investigation. Or it is dyspnea. So what was the respiratory rate? What was the saturation? Was there any requirement for oxygen? Or was there any other which was intervention which was required? So it provides objectivity to your signs and symptoms. Thereby, it improves the accuracy of reaction classification and imputability assessment. And also it enhances the quality and completeness. So at the time of analyzing, if you're providing objectivity to it, it provides a more complete and quality data, so which can be analyzed by the reviewers, and then it helps in the further development of preventive strategies. So this Hemovigilance program also, it is a symptom-based approach. So by reporting all the signs and symptoms, it helps us in evaluating and confirming and reaching out to the diagnosis of any transfusion reaction. So the next section, the third section, is the transfusion product details. In this, it covers the type of the component and the number of transfusions. Now, what is the importance of recording the number of previous transfusions? So it identifies the high-risk patient populations. For example, the patients, like if you are reporting it as repeat more than 10 transfusions or 1 to 10 transfusions. So these, they identify the chronically transfused patients, for example, thalassemia patients or any other cancer patients. So thereby, it helps us to know whether the frequency and the type of the adverse reactions, they increase with the number of transfusion. received and thus support the epidemiological analysis. We can identify the trends, the patterns, and the risk factors. As it has been identified that febrile non-hemolytic transfusion reactions, they are more in repeatedly transfused patients as compared to the patients who are receiving blood for the first time. Thereby, it helps in guiding policy decisions. So importance of the type of the component is that now different components, as we have already studied since morning, that different components, they may be associated with different reactions. For example, the plasma components, they are more associated with your allergic reactions. Like hemolytic reactions, they are reported following your red cell transfusions, or your FNHDRs, we have said it is more common following your cellular components like your red cells or platelet transfusion. So by analyzing this, and even the platelets, as we have discussed, they are more associated with they have the highest risk of bacterial contamination. So it is from the skin flora. So it was then they took that if we divert 15 to 30 ml of the initial blood, then it can decrease the rate of your bacterial detection. So this is how the diversion pouches, the preventive strategy was devised, and by the introduction of these diversion pouches, there was a decrease in the rate of bacterial detection. So then comes the fourth section is the investigations. It has been brilliantly taken by the previous speaker, Dr. Gopal. What are the various investigations which need to be done to establish the diagnosis? Then from the basis of all this, what were the investigations, the signs and symptoms, the vitals, we come to the nature of the adverse reaction. So in this, it comes the nature of the adverse reaction, then the date and time of onset. So this is also very important. Date and time of onset helps to establish the temporal association with the transfusion. As we are saying that this reaction occurs, like we have stressed, that FNHDR occurs during or within 4 hours of transfusion. Allergic also occurs during or within. Trali occurs less than or equal to 6 hours. So thus by giving this data, it helps us to establish the temporal association with the transfusion. And it also helps us to even identify any delayed or prolonged complications. Then date and time of recovery, it lets us know what was the clinical impact of the reaction or the outcome, what was the severity of the reaction, and how long did that adverse event took to recover. So then is the imputability assessment, that likelihood that whether that event was because of the transfusion or due to some other reason. So now this is another which has been added is the section is the denominator data. So by reporting now this means that it now mentions the number of units which have been issued during that reporting period. So by reporting this, we are able to determine the rate or the incidence of the transfusion reaction, which helps us in comparing it with the other institutes or with other countries. So rather than just the number of the reactions. So this is the various data which has been reported till now. Now, what is the importance of completeness of the data? So complete data is a data which contains all the useful information without any missing or incomplete data. So this was a Hemovigilance newsletter which was published in 2021. In this, out of the 4259 transfusion reactions reported in year 2016 and 17, so 38 reports, they were excluded from the analysis, and out of this 38, it was 17 reports that were excluded because of the incomplete data, and the 9 reports were because of the discrepant data. So this is an annual short report in 2025. So in this also you can see that out of the 72.8%, they are the complete reports, then 10.5% are the incomplete reports. So now coming on to the various cases which I'll be discussing. So stressing the importance of the completeness of this. So this is the first case. In this, the patient was had a diagnosis of a road traffic accident with a polytrauma. So in this, the reporter has mentioned that the patient experienced fever with tachycardia. But as you can see, the reporter has not recorded and has not given any objective evidence of this fever, that the pre-transfusion temperature is or the temperature during the transfusion is also not recorded, or whether the tachycardia, the pulse rate has not been mentioned. So then the reporter, the hemolytic transfusion workup was done and it is appropriate and it was found to be negative. So acute hemolytic transfusion reaction is ruled out. Then the reporter has not, the blood culture of the patient, the blood bag is not done. So the blood culture, so you have not ruled out bacterial contamination. So then they have established it as to be a febrile non-hemolytic transfusion reaction with 2 degrees Celsius rise in temperature. But it has no objective evidence of, there is no objective evidence of the vital. So there is no bacterial contamination has not been ruled out, and even polytrauma itself can cause fever. So then the next report is the acute pancreatitis. So in this, the reporter has very well mentioned the objectives. So the patient experienced fever and they have mentioned the recorded the temperature. Initially it was 36.89. It increased to 38.89 degrees Celsius. So the hemolytic transfusion reaction workup was also negative, and they've also ruled out the transfusion-associated sepsis. The culture of the blood bag was done. It was found to be negative. So they have mentioned it as FNHTR with 2 degrees Celsius rise in temperature. It is agreed. Then, so this is another common confusion between the Fahrenheit and Celsius confusion. So over here, in the first report, as you can see, the reporter has mentioned the vitals, has mentioned the wrong unit. So it, instead of writing it as 99 degree F, they have mentioned it 99 degree C. So this has converted it to like this. So this is a common confusion which can lead to your discrepant reports at the time of analysis. In this, they have made the wrong entry. So you can see 90 degree F and 95 degree F, it amounts to hypothermia. So 32 or 35, which is very highly unlikely in a stable patient which is having an itching or a redness, just an allergic reaction. So, and this, the third report again, you can see there is again a wrong unit has been entered at the time of entry, that instead of 35.6 degree C, they have mentioned it as degree F. So you have to be very careful when mentioning when entering the data. So this has been, the conversion has been already incorporated in the software, and it is a formula based calculation, as you can see. So in this report 3, so the patient had this pain abdomen and the patient complained of chills and nausea, with the vitals, they were within the normal limits. And then it was following the transfusion of Buffyco depleted PRBC. The hemolytic workup was negative and the blood culture of the blood bag was also negative. And so now the symptoms that the reporter has mentioned it as chills and nausea, but the adverse reaction it is mentioning as allergic. So this is a common confusion. If there is no fever, then chills and nausea, they are misinterpreted as allergic reaction. In fact, it is a febrile non-hemolytic transfusion reaction rather than an allergic reaction. So this is another report over here. So this was a case of thyroiditis. The patient had chills, itching and urticaria with dyspnea following transfusion. The temperature was pulse and blood pressure. So there was hypotension as the BP fell from 120 by 80 to 90 by 60. For the dyspnea, there is no objective evidence of the respiratory rate or the saturation. The reporter hasn't mentioned. It was following the transfusion of FFP. So the hemolytic workup was negative. And so over here, you can see now they have listed 4. They have categorized as 4 reactions: allergic, anaphylactic, hypotensive, transfusion, and all have been given definite imputability. So first of all, as we have already discussed, hypotensive transfusion reaction and transfusion associated dyspnea, these are the diagnosis of exclusion. So once we have excluded all other reactions, the patient underlying condition, then you have to make this diagnosis. And by going by the symptoms, as the patient had itching and urticaria along with the hypotension, so it could be probably a severe allergic reaction. So you have to be very careful while entering the data, while making and corroborating it with the signs and symptoms. So thus the take-home message is that complete data, it will enables accurate classification and imputability assessment of adverse transfusion reactions. Accurate and timely reporting to the Hemovigilance program, it is crucial for enhancing transfusion safety and improving patient outcomes. Thank you.
Thank you, ma'am. May I now please call upon our next speaker, Dr. Hemchandra Pandey, sir. He is the additional professor and head Department of Transfusion Medicine here, and sir would be taking us through the responsibilities of stakeholders.
Thank you, Dr. Sitija. So the previous speakers have actually made my talk a little easier because as Dr. Sitija highlighted that a lot of time we miss a lot of fields in the TRRF. So that may be because a lot of stakeholders are not knowing what their responsibilities are if they are participating in a hemovigilance system. So before I go there, I would, it's a very generic system which I have tried to make. It starts with either donor or patient event. The hemovigilance system starts with the basic donor or patient event. It goes on to a local reporting that could be a blood center or a hospital, depending on whether it's a hospital-based blood center or a standalone blood center. Then there is a local investigation and data collection. It is followed by reporting to the National Hemovigilance System. Once the investigation and data points out to a certain adverse transfusion reaction, we'll be reporting to the National Hemovigilance System. Then the processing of data at the National Hemovigilance System of the whole country, followed by some feedback to the Ministry of Health or regulatory authorities, as well as to the blood centers which are actually participating in the hemovigilance program. And this follows corrective and preventive actions or changes in guidelines or policy making. And ultimately, the feedback goes to the institution. So this is just a brief flow of how the hemovigilance system actually works and leads on to improvement. Now, at each level, there are certain stakeholders, and each stakeholder has certain responsibilities, which, if clear, helps in better reporting and better outcome of the whole process. Now, who are the stakeholders? So when we see the event occurrence, we'll see that donor patients are one of the stakeholders. The major stakeholders which have really good responsibilities are highlighted in bold fonts. So here at the level of event occurrence, clinicians, nurses are the ones who have major responsibility, and there is some responsibility of transfusion medicine team also. At the level of local reporting, again, clinicians and nurses have a very important responsibility, as well as some role of transfusion medicine team do come at that level. Then when it comes to local investigation and data collection, it is the transfusion medicine team as well as the laboratory technical staff which has the higher responsibility as compared to clinicians, and there is some responsibility of HTC also. We'll come to them one by one. Then the hemovigilance program, again, I have given example from India that here HVPI or NIB India has a responsibility as they are one of the biggest stakeholders in this whole process, and there are core committee members which again have some responsibilities. Then there is regulatory authorities who have a certain responsibilities, like in India BTS division and BTC CDSU do have a responsibility in the whole process of hemovigilance, and in broadly we can say that policymakers do also have a responsibility. Then coming to the current event priority actions, again here SBTCs, the core committee may have identified some aspects which can be improved, some policy changes may be needed, but the corrective and preventive actions may be taken at the level of hospital or the blood bank by QA teams, or at the level of state by the SBTCs, which governs the state level blood centers. Now let us understand this whole responsibility thing with the case. So I have taken a hypothetical case. Mr. Rajesh, 52-year-old, admitted with severe anemia, secondary to GI bleeding. He received 1 unit of PRBC in the ICU. So 10 minutes into the transfusion, the patient calls to report that, oh, I'm not feeling very well, I'm feeling uneasy, something is wrong with me. So immediately the nurse attends the patient and notices that sudden chills, there are sudden chills, fever is there, and the patient is having tachycardia. So see here, nurse is the first stakeholder. So usually the nurses or the in our setup, maybe the clinical residents are the first responders who are the first stakeholders. So the nurse took some actions. She immediately stops the transfusion. She keeps IV line open with normal saline. She checks vitals and documents them. She reassures patient. Then she calls the treating physician and informs the blood bank also. And then she sends the blood bag and IV tubing back to the blood bank with the reaction form. So these are some of the actions, major actions which the nurse is doing at the bedside, and they are the first line of defense, because if detected early we can prevent catastrophic outcomes, like in case of a hemolytic transfusion reaction. If we stop the transfusion immediately, we would be able to save the patient from a lot of morbidity as well as mortality. So these actions are defined by some responsibilities. So responsibility of nurses, ward staff or ICU teams is that they are the first responders at the bedside for every transfusion. They have a responsibility of continuous monitoring of patients throughout transfusion, not only when a reaction is suspected. So the responsibility is not only when reaction occurs, it is actually when they start transfusion, they prepare for transfusion and the transfusion is completed and monitoring is completed. Then they are the bedside link between the patient, treating physician and the blood bank. So in the case, the nurse actually took some actions at the bedside to the patient, then she called the doctor, then she called the blood bank. So they are a link between patient, treating physician and the blood bank, and they have a very good responsibility or great responsibility when it comes to hemovigilance systems. Now coming to the action of clinicians. So the nurse has actually called the clinician that such and such patient has undergone adverse transfusion reaction. The physician arrives and evaluates the patient. He confirms that yes, a transfusion reaction has indeed occurred. He orders certain investigations. He asks for a repeat ABORH, a DAT, hemolytic markers, and he sends a urine sample for certain analysis. Then he immediately provides symptomatic treatment, antipyretics, oxygen, fluids, or depending on what kind of reaction it was, and he documents the clinical findings. Then he discusses the case with the transfusion medicine specialist that so and so reaction has occurred and I have taken such steps. Should I take some other steps, or is there something which I have missed in the management of the patient? So you see, it's a teamwork, and the responsibility that physician determines the clinical severity. He took actions and ensures patient stabilization. Now, by this we can actually find out what are the responsibilities of a treating physician. So a treating physician has a responsibility as well as clinical accountability for diagnosing and managing transfusion reaction. They are the ones who have a responsibility to assess imputability, whether the reaction has actually occurred because of transfusion or there is something else going on irrespective of transfusion, because it will define how they manage the patient. Then they have a responsibility of classifying the severity of the transfusion severity along with the transfusion specialist, and they also have a responsibility to collaborate with transfusion medicine colleagues or the blood bank colleagues in making correct diagnosis as well as in managing the patient correctly, because a lot of times the symptoms may not be pointing out to the correct diagnosis or correct adverse transfusion reaction. So they also have a responsibility that they discuss it with their colleagues in the blood banks and come out with the correct management of the patient and diagnosis. Now, at the ward level, the nursing staff and the clinical in charge have taken action. But once they have reported and sent the blood back to the blood center, what are the actions at the level of blood center? So the blood bank, as the sample and the information reaches blood bank, the lab technician would inform the transfusion consultant, because they are the first line of contact at the level of blood bank. So he informs the transfusion consultant, performs a clerical check to see if the patient is right and the unit which was issued and transfused was the right unit for the patient. Then he repeats the blood grouping and cross match. He conducts that hemolytic workup, and he visually inspects the plasma of the bag as well as the patient sample, both pre and post transfusion samples. He documents these reports. He maintains the traceability, or he finds out the traceability of the unit, the patient, and whatever has happened before the transfusion has occurred. Then he enters the preliminary data in the records also. So you in addition to that, the transfusion medicine specialist also arrives and he reviews the patient history as well as the previous transfusions. They would help in making the correct diagnosis. Then he classifies the reaction along with the clinicians who has attended to the reaction. They both determine the imputability, whether it was definite, probable, possible, unlikely, and he communicates to the clinicians for the further management. And finally, he prepares a detailed hemovigilance report. So some blood centers have a hemovigilance nodal officer who actually prepares this hemovigilance report, though a lot of times um, blood bank specialist would be the one who would be preparing these reports. So at the level of blood center, there are certain responsibility of the stakeholders at the blood center. So laboratory technologist has a responsibility of checking the compatibility, infectious marker testing for every unit. They have a responsibility for end-to-end traceability from donor to recipient, because that would actually help in diagnosing a lot of errors and identifying the right diagnosis of the patient. They have to also see any kind of document deviations, non-conformities, and reaction workup responsibility also lies with most of the time with the laboratory technologist. Whereas the transfusion medicine specialist is the one who owns the final classification and imputability of reaction, and that's a very big responsibility, because on one hand it would help the clinician in managing the transfusion reaction. On the other hand, all such reported reaction would help build the hemovigilance data at the level of the reporting system. Then he has a responsibility to submit the hemovigilance report to the national system and provide feedback to clinical team, as well as communicate and coordinate with the hospital transfusion committee. So we don't only want that national level improvement occurs. There may be something which in a particular hospital or a center needs to be changed or needs to be improved. So the transfusion medicine specialist communicates with a lot of people, and the responsibility is very big. Now coming to the responsibilities of quality manager. So a lot of times, at least in majority of our centers, there is no quality manager, and the job is being done by the transfusion medicine specialist only. But if you have a quality manager or a root cause analyst, they have a responsibility of performing root cause analysis for all these transfusion events. There may be some near miss events which would help us in preventing future transfusion reaction. Then they have a responsibility of identifying process gaps, and even if there are proper processes, there may be deviations from those processes, and identifying those process deviations. Then they have a role or responsibility in recommending the kappa, how this can be corrected and what preventive actions can be taken, so that in future we can increase the blood safety. And they also have a responsibility to monitor compliance with safety protocols. So there may be protocols, but the compliance may not be good. So a quality manager in the hemovigilance system at the level of hospital or blood bank has a very strong responsibility, and they also have a role in supporting HTC in quality improvement. Now uh, these are some things which are default or are present in most of the blood center. But now another stakeholder has role has been building up in the last few years, that is the hemovigilance nurse. So hemovigilance nurse is specifically trained to actually identify, monitor, collect data, and see that a transfusion reaction is properly attended and reported. So wherever hemovigilance nurses are there, they are another stakeholder in this chain, and they have a responsibility of identifying and documenting adverse transfusion reaction, collecting, reporting data to national facility level hemovigilance systems, investigating events, educating staff and donors on safe transfusion practices, and reporting procedures. So this is another stakeholder which is developing in most of the blood centers across the world. Now in this case, this is still the level of blood center. Now blood center in charge has reported this to the hospital transfusion committee. So what are the actions at the level of hospital transfusion committee? So HTC reviews the case in its monthly meeting, or whatever frequency the HTC is functioning. So at our institute we function either quarterly or 6 monthly. So whenever the meeting will occur, HTC has a responsibility to review the case in monthly meeting or whatever frequency they are happening. They analyze whether the reaction was preventable. They see the trends at their hospital level. Are similar reactions increasing? they recommend corrective action. So recommending corrective actions in the form of staff retraining, SOP updates, equipment recalibration, etc., is again responsibility of the hospital transfusion committee. They also ensure that blood bank and clinical teams follow protocol. So if both the teams are not doing well, STC can actually review the whole series of events, and then they can ensure that everything works as per the SOPs and guidelines. So STC has a responsibility to ensure system level safety. So STC oversights all transfusion reaction and donor adverse event beyond the individual case, ensure compliance with hemovigilance reporting timelines, and conduct periodic records of transfusion practices. They ensure that hospital-wide adherence to hemovigilance protocols is maintained. Now, this is at the level of hospital. So this data is then reported to the National Coordinating Center. In our case, it is HVPI at NIB. So this is a kind of a data aggregator level, where after the blood bank submits the hemovigilance report, they receive the case data. The case data are received from whole country. Then they analyze the national trend. They detect signals like rising allergic reactions nationwide. So one center may not have sufficient data, but if we see, so they can look at that whether there is any change in the blood bags, some material change has occurred, there has been some deviation in some consumable. So they can get these signals, and they can issue advisories if needed, and they provide feedback to the hospital. National bodies convert individual cases into national policy improvement. So they have a very big responsibility of publishing national hemovigilance reports, coordinating training and capacity building program based on these signals, based on the trends which they find out from the individual data from blood banks. And they also have a responsibility to escalate safety issues to regulatory authorities. So if there are some things where regulatory compliance is required, they can actually coordinate with the regulatory authorities. Now, there was something which needs to be taken care at the level of regulatory bodies. So, at the level of regulatory bodies, suppose in this particular case, they found that multiple reactions were noted, and a particular kind of blood bag was involved with these kind of reactions. So, the regulatory body will investigate whether a particular blood bag supplier or reagent is problematic. They'll issue safety alerts, and they will update the national transfusion guidelines. They will ensure that countrywide blood safety in regulatory compliance is ensured. So the regulatory authorities have a responsibility of using that hemovigilance data for regulatory decisions on blood safety. They also have a responsibility of ensuring or enforcing compliance with national blood safety standards. So to conclude, there are multiple stakeholders, because hemovigilance is a continuous chain from patient bedside to national regulator, and every link matters. Because if we are not reporting correctly, the blood bank is not getting the reports properly from the ward, will not be able to report. If we are not reporting properly, the national aggregator will not be able to find out those trends. They will not be able to tell the regulators, and the safety will be hampered. So nurses detect, respond first, while clinicians diagnose, stabilize the patient, and order investigations. Lab technologists and transfusion medicine specialists again investigate, classify these reactions, and establish imputability. Quality managers, HTCs, national bodies drive root cause analysis. They'll tell about kappa, and they will ensure system level safety. When every stakeholder owns their role, timely reporting and feedback continuously, it will ultimately improve the transfusion safety. Thank you very much.
Thank you, sir. Our next speaker is Dr. Rahul Chaurasia, sir, from Department of Transfusion Medicine. Sir is an additional professor and also a member of ISTB, ISBT, and AABB. He is a reviewer of esteemed national and international journals and has also received Harold Gunson Fellowship Awards. Sir has more than 32 publications in various national and international journals and contributed to several chapters. Several intramural and extramural research grants as PI and co-PI. Sir has been a part of it, and Sir would talk on institutional case study.
Thank you, Dr. Shilja. While my previous speakers have talked about how hemovigilance works, how we should collect the data, how should it be reported, and what are the responsibilities of the stakeholders, I'll be walking you through what how hemovigilance or the surveillance system works at an institutional level. So before I start, I like to set a background to what is the transfusion chain. The transfusion chain just starts with the sampling of the patient when the decision to transfusion is made, and it is after the decision to transfusion is made, the prescription is written in the patient file, then the requisition form is raised, sample is drawn, pre-transfusion testing is being done in the blood center, the samples are sent to the blood bank where it is done. After that, the blood is being issued to the ward where it is received, checks are performed before transfusion, and lastly the transfusion and the documentation of the vitals and the adverse effects or the outcomes of the transfusion itself. If we simply see these components of the transfusion chain, each step has various sub processes, and each of them has a certain degree of risk which can ultimately impact the patient outcomes. It may be an adverse reaction or it may be a good successful response also. So the first step is like need or the clinical alternatives of transfusion are whether explained, prescription is written, what is the schedule, dose, consent is being obtained, any previous transfusion history or historical blood group records are available, then the requisition is drawn, samples are drawn, labeled, sent to the blood bank through a transporter. Then, after the sample and the requisition forms are received, blood grouping is done, blood units are being selected, cross matching is done, a compatibility report or a cross match report is prepared, and then it is again sent to the ward where these checks are again performed. So, in order to assure that the blood that was issued from the blood center is compatible with the patient and it will not harm the patient. At the time of transfusion, patient identification is done, checks are performed, and transfusion is done along with the documentation. And lastly, the documentation part also includes the pre-transfusion vitals, whether the patient was having any previously fever or not. Then during or after the transfusion, continuous monitoring to identify any adverse reactions or adverse outcomes. The outcome of the transfusion itself, whether it was good, successful or not. And lastly, if there was any adverse reactions, how was the management done? And all these are a part of the transfusion reaction reporting form as previously talked by Dr. Shitja. So adverse reactions are inherent to the blood transfusions, and some of these reactions are preventable and some are non-preventable. So we will be talking mostly about the preventable transfusion reaction where we can give some inputs and prevent those reactions. So if we talk about the short data itself, around 80% of the transfusion reactions are preventable, and around 10% or 5% are somewhat preventable, and remaining rest of those are non-preventable. So if we have such a huge chunk of preventable transfusion reactions, there is definitely a institutional role or a blood center can play a significant role in preventing those transfusion reactions. So preventing is like we have several weak points in the transfusion chain because of the human involvement or because of the clerical errors which can be in the blood center or can be in the ward. So we, in order to prevent those reactions, we need to work upon those weak links, set a quality check or a safety check on those points, and then we can improve on. So just remedying the adverse reactions is not also important. We need to perform a root cause analysis and so that we can address all the risk factors like man, machine, material, management, and mother nature, that is the environment. And after it is done, a corrective and preventive action is done so that these adverse reactions or adverse outcomes don't get repeated in the future. While we are looking at the adverse reactions, in the transfusion reactions forms, we just saw that transfusion reactions or adverse events are being reported. What is not being seen is the near misses. And like earlier in the presentation, Dr. Shruti said, near misses comprises a major or huge chunk, almost 90% of the reactions that we are not seeing through. So recognizing those near misses is much more important than the adverse events itself. So, hypothetically, I will begin with a case where a 45-year-old male patient was admitted in orthopedic for a surgery and he was transfused with 1 unit of blood. Just after 5 or 10 minutes of transfusion, the patient started having uneasiness, back pain, chills, fever, nausea, vomiting, hypotension, cola-colored urine, which is a typical presentation of a hemolytic transfusion reaction. His vitals was also deranged, and like every clinical site, the transfusion was halted and emergency care was commenced. Now, what's next? The next step is, as per the transfusion reaction form, a fresh sample of the patient was sent to the blood center along with the blood unit that was being transfused. And during the workup, it was found that the patient's group was O positive and the blood group was A positive. So here there is a classic hemolytic transfusion reaction because the patient was O group, A group was transfused patient, and he had undergone a hemolytic transfusion reaction. So there could be possibly three causes. Either the sample was wrong, which could be a pre-analytical step, or the blood group itself was not correct, and hence a blood unit that was issued was incorrect. And lastly, the incorrect patient was transfused because of the checks or errors at the bedside during the transfusion. So this can be basically classified as pre-analytical, post-analytical, and analytical steps. So we need to look into these steps. So I'll be taking one by one these steps. First, wrong sampling, that is the pre-analytical. It could be an identification error, whether the patient was not identified properly or there was writing error, the consent was not taken, label was not properly attached. So ideally, we should go for a two-step validation. Either we need to have two identifiers, or the patient identification should be confirmed by one more person, so that the details are verified and there is no identification error or labeling error is there. But that does not suffices. That in the real practical world, that does not work. So we need to have some extra works, and that can be in the form of a patient identification band, barcoded sample. We can also have a integrated IT systems or information management system where all these can be. We can have at least one check we are doing, and the second check could be done by the automation or the IT infrastructure. The second is the testing error. In blood bank, things can go wrong, the samples can get exchanged, anything can happen. It could be clerical error, reporting error, or labeling of the blood bags could go wrong. Technical errors are also a major part of it. But in blood bank, we generally have a two-step or a multiple-step validation process, and it follows the cheese uh, principle. And only if multiple things can go wrong, then only this happens. In blood banks, generally what we happen, we follow a two-step validation. One person enters the report, the another person validates it, looks through it, and gets it validated. So in this order, we can also put extra efforts in forms of the barcoded samples automation system and a link between these two by an IT or information management system. Lastly, coming to the post-analytical step, while the blood is being received at the wards, there are a number of documents that needs to be cross-checked along with the patient records. It include a compatibility form, a cross-match label, a blood bag label, which includes a lot of information, blood group, date of collection, date of expiry, everything, a lot of things. So here, if the identification is going wrong, we could simply have some sort of system like the usual protocol, transfusion protocol. The blood before transfusion needs to be checked by two nursing officers or one nursing officer, one resident, so it is there also. But identification band is indispensable at this step. Now if any wrong blood is issued, this is the most critical step where it should be checked. So while the error is identified, the root cause needs to be addressed. So it is important getting to the roots. And this is one of the experiences that was published in Vox Sanguinis from our center. And it was analysis of wrong blood in tubes, events at the hospital-based center. So wrong blood in tube, this is basically is like two samples. There are two patients who need sampling, and the samples get swapped or the labels get swapped among those. So in this study, data of around 3.5 years was collected retrospectively, and they identified that the risk of WBIT events was around 4.8 per 10,000 transfusions. They looked into what was the details of the demographics, they identified that the urgent requests, majority of the blood centers or the clinicians want my blood to be issued urgently. So the urgent requests were more prone for WBIT errors. The another thing that was commonly identified, the timing of the transfusions. Most of these wrong blood in tubes are happening late in the night, from 8 p.m. duty to 2 a.m. duty. Then another thing, the specialty wise, they found out that the surgical disciplines were more prone for having WBIT events. And while we look at the data, individual department data, we identified that only some centers were having, sorry, only some centers were having huge, like in the earlier slide, earlier line we showed that surgical discipline was having the most uh, highest WBIT events, and acute care was having the lowest. But when we have a breakdown of the trauma services and the emergency medicine itself, we found out that the trauma was the most prone thing. Similarly, for the medicine, the gastroenterology department was having more WBIT than the other departments. Now, coming to the WBIT description of the total 79 WBITs, it was found that 75% cases were identified prior to the transfusion. And it was possible because of the historical blood group was already available in the system, where in the information management system, and this prevented the wrong transfusions. So these were no harm events and were classified as near misses. In rest of the 20 cases, 4 cases of the patient or the staff itself flagged that my blood group is such and such, or blood group in the file is this, why are you going to transfuse this thing? And it was possibly because the patient's blood grouping or the historical blood group was already available in the patient file. The other 10 cases, no transfusion or compatible blood was given. Like I said, in the earlier case, the patient was O group, A group was being given. What if the patient is A group and O blood was issued? So this was a compatible transfusion, and the patient was fortunately saved from having any HTR. In another 6 cases, there was adverse transfusion reactions. While we tend to think that in 4 cases there was no harm because the patient or the staff flagged, or no or compatible transfusion was given, but eventually we can see that the transfusion may have been delayed, and it could itself have caused a adverse reaction because of the delayed transfusion itself. Now, coming to the root cause of the WBIT events, several after during the investigation, the phlebotomists were interviewed, and what the root cause was looked into, and most commonly it was identified that the residents or the phlebotomist was having lack of knowledge or training how to do a phlebotomy. Earlier during the day, it was also emphasized on that phlebotomy needs to be training or retraining should be done. SOP availability of phlebotomy or sampling at the bedside was not available. Human factors like exhaustion come into play, as we can see from the late night phlebotomies or late night WBIT events. Similarly, these were the major causes. In some cases, there was human factors, but majority on the majority side, it was the lack of SOP or the lack of information. So, what can be done to address these cases, and what was being done? Training, retraining, and while we were seeing these kind of events, we initiated training sessions for residents as well as for the nursing officers in 2017 to our CMIT facility. We also have a CME series labeled as Blood Safety and Quality. Then we have several sampling protocols which were circulated throughout the hospitals for so that the sampling gets improved. Then raising awareness. These are some of the work instructions that can be put up. Then there could be SOPs which could be easily available at the bedside or at the nursing station. Simulation on how we should work on the in case of adverse reactions, increasing the manpower, or seeing the time of the sending most of the requests at urgent is not going to happen. We need to work on how we can reduce those urgent as routine transfusions. Now, lastly, installing or implementing controls at critical checkpoints, like at the bedside before transfusion, there has to be 2 people who should do it. And how we should do it, there could be, nowadays technology is advancing, we could have a RFID based technology, or we could have other mechanisms, barcoded mechanisms, which can be put up in place. And lastly, work instructions at the bedside for sampling and for before transfusion. And all this goes on. This is not a one time event, it is a continuous process. So we need to have a regular audit, and upfront we need to have a audit criteria which should be institutional. We need to identify other areas of concern. Like I said, near misses cannot be ignored. We need to work on the near misses as well, monitoring any intervention or changes, whatever interventions we have put up. We need to work up, monitor again, do it, and formulate policies and guidelines. And we need to regularly check on those guidelines and policies that we are performing as we are desired. And all this could be done at an institutional level through a hospital transfusion committee, where all the stakeholders of transfusion, not merely blood transfusion or transfusion medicine, but the users of the blood should be there. Then it has a very simple process, but a complicated one. Though it seems simple, but it is a complicated one, where we needs to go through a multidisciplinary process, through a lot of discussions, through a lot of consensus needs to be there. And it's simple plan, whatever you want to do it, check it again, manage it, and again do the process again and again. Thanks a lot.
Thank you, sir. We now would request Dr. Satyam Arora, Additional Professor, Department of Transfusion Medicine, Postgraduate Institute of Child Health, Noida. And sir would be talking on challenges, impact, and way ahead in hemovigilance. And sir is a certified advanced biotherapy professional by AABB USA, awarded Renzo Gallenlo Fellowship 2025 by NHS UK. He has international roles as Regional Director, Southeast Asia for the International Society of Blood Transfusion. Sir is a chair, Pediatric Transfusion Subgroup of ISBT, and has a national role as a member of panel of experts for the National Donor Vigilance Program of India, member Special Interest Group on Blood Donors Management by ISTM. Sir has been awarded with Best Abstract Award 2026 by ASFA, Director's Medal for Best Teacher Award by PGICH 2025, Narendra S. Bagaria Award by ISBTI 2022, Young Scientist Award by ISTM 2021, Dr. Harold Gunson Fellowship by ISBT in Mexico. So has more than 65 publications and total to his accolades. I would now request Sir to kindly speak on challenges and way ahead in hemovigilance.
Thank you, ma'am, for your kind introduction. And yeah, I will probably be concluding this webinar with this presentation, which is on impact, challenges, and way ahead. And I will be discussing them as yeah. Okay. So I will be discussing global updates and the impact of hemovigilance. What has been the benefits, challenges, and how I feel can be the work ahead. So what are the global impacts? And this is the last, blood safety report of WHO, and the shaded area talks about the countries which present or which have some hemovigilance program, or there is some reporting system. And if we see how we have come to this level, initial work has been from UK, Netherlands, and France, that they started this concept of hemovigilance in 1995, 96. Then Canada started it in early 2000, which was followed by the initial work in Japan and United States. And since morning, we have seen many reports from these countries. Gradually, countries like Singapore and Australia brought hemovigilance on the center, and they also integrated PBM with this hemovigilance program, which was an interesting way of putting, the hemovigilance program. As we came along in the last 2 decades, or last more than 1 decade, Brazil, South Africa, and India came up with their national programs, and we saw with this morning CME that how in India since 2012 we have a well established program capturing both donor and recipient data. So what has been the impact? So the countries which have implemented hemovigilance, there's been this as a driver for quality improvement across the systems. It identifies risks, failures. You have some strategies against which there are fewer errors, as we saw with the shorts presentation, fewer reactions, better process, and higher quality. Then there is more donor retention and sustainability with because of the donor hemovigilance. There are more regular donors. There is international standardization and harmonization. We've seen work coming out of ISBT and IHN that how consistent benchmarking can be achieved with this global collaboration. And then for our policymakers and regulators, we have better decision making with stronger policies, effective regulation, and improved public health outcome. So what we eventually want is better transfusion care for every patient every time. And what we measure, what we understand, what we improve, and hemovigilance can actually save lives. So when we see locally, in India, did the hemovigilance actually made any difference? And this was a work which was led by Dr. Gopal at the national level, where we evaluated the decade-long hemovigilance program, and this was a survey-based study by the national program, and 296 centers or blood center responded to it, and 89.9, that is 90% of the centers, found that blood center policies have changed and resulted in improvement. And there was a notable enhancement of recipient safety with implementation of the hemovigilance program. So now this is our Indian feedback to why we should have implemented this program and what is the outcome. Now coming to benefits, when we look at benefits, the first part is quality, and I personally feel data driven decisions. When you have some data, like from donor hemovigilance, we have 90% of all donor reactions reporting within 30 minutes of a donation. So it gives us good evidence that the donors should be monitored for 30 minutes at least after donation. Then that can give us corrective action, more standardized procedures and policies, and by analyzing our own data, we can be consistent and propose more safe practices. This includes redefining donor screening processes, improving phlebotomy techniques, enhancing post donation care, and similar to the recipient side, and provide more material for your in-house training and education, and this CME and webinar is part of that. Coming to donor retention, so because donor hemovigilance really improves donor retention, it enhances the donor experience. There is a positive experience. Donor center keeps a track of these donors. There is a concern for the donor. It builds trust with transparency. So more donors are encouraged to come back to the same blood center and become repeat donors. More personalized care. When you call back a donor and ask him whether he's okay, or if there was a reaction, you just call up and ask whether he's better, whether he's improved. All this brings a lot of personal care, and that improves satisfaction, improves the retention care. International standards. So now our data, because we are using same guidelines, same definition, and same severity, it is more internationally comparable. We are achieving international standards. We are looking at these things with a global perspective, with identifying best practices and needs for improvement. There is more benchmarking. So the data that India is putting out is now comparable to the data from different countries, and it can also locally you can benchmark your data with the national numbers that you're achieving. Now we are looking more at collaborative research. So experts from India in hemovigilance domain are now able to collaborate with the country data into multiple different global analysis, and which can become a big driving force for hemovigilance in coming times. Coming to policy, more informed policy making, we have our own data to make our own decisions and give more evidence-based approach to support development of regulation. Regulatory compliance, so now even regulators look at data from hemovigilance to see whether your reports are in line with the national guidelines, and there is more compliance check from that side. And then continuous improvement. So continuous monitoring leaves gives us an option of continuous improvement. So this is just a snapshot of how what can be the benefits both at donor side and recipient side. Improving safety, quality improvement, enhancement of donor experience, and better clinical outcome. We have more product assurance because our donor is taken care of. In the recipient side, there is more evidence to the guideline, and again data and benchmarking and accountability. Coming next to the challenges. So what are the challenges that we feel? So another thing is, when you start hemovigilance, you need to have clear definitions, uniform definitions, and that was an initial work which was done by ISBT and IHN and helped us take those guidelines. But we are seeing more new conditions, more new adverse events. There's a revision of diagnosis of definition of TRALI. There is interesting work coming into TACO. So again, it's a continuous process to redefine these definitions and harmonize them. And hemovigilance data have potential to establish benchmarks that can impact policy change, modify clinical practice, and ultimately improve outcome. But these relies on universally understood and applied, vernacular, and they can be used if you're using the same term. So the willingness of blood donors to provide critical resource mandate as a reciprocal robust system to protect donor health, which begins with validated, objective, consistent measure to carry out effective donor hemovigilance. Now coming, another next challenge is imputability, and that is where now we have a score for severity, but there's a team which is working on imputability. We have new products. We are entering into the era of gene and cell therapy and stem cell transplant, and with SOHO regulation coming in from Europe, this will again, be the ambit of biovigilance, which we would like to, see if that can be included. Again, we are not yet assessing the delayed reactions or delayed adverse events, at least from the donor side, and that will also, I feel, is still a challenge and something to look ahead. And again, rare and serious complication needs more attention, and they need to be reported regularly. Long-term effects of donation like fatigue, iron depletion, and the effect of repeated use of anticoagulants and their effect of likelihood of risk of osteoporosis, use of growth factors which are being given to granulocyte donors. So again, these are something areas where hemovigilance, at least nationally in India, is not looking at these areas, but definitely that is a way future that we would like to look at. Coming to way ahead, I think I've tried to use an AI module just to make it more understandable. Expanding our vein to vein vigilance, monitor every step of transfusion medicine, harmonizing international standards and more definitions, more common terms that we are using so we can compare that data. Digital transformations, I know it's a Achilles feat for us that our hemovigilance software website is still not active as it should have been. But again, digital transformation using AI predictive models with the data that we have in hemovigilance today, both in recipient side and the donor side, can be something next that we are looking at. Integration of PBM, again, hemovigilance integrated with PBM was a model initiated in Australia. This is something that can be the future for optimal utilization of blood components, reduce unavoidable transfusions, improve patient outcome, and optimal use of our resources. Now expanding our scope to SOHO, this is something that I feel is the future. Not only blood, products like human milk, tissue, organs, cell, everything, bone dust, everything will come into biovigilance and SOHO, and follows the same principle as we do in blood bank. We need to include newer therapies, and the hemovigilance need to, or biovigilance need to cover them, as cell therapy, transplant, CAR T, gene therapy, and regenerative therapy, even PRP therapy, which has been given very as a local therapy at many clinics. Strengthening LMIC capacity, and hemovigilance is a huge has a huge potential to improve blood safety in LMICs, and India is leading with lot of guiding lot of countries around South Asia to get their system on board. So stronger surveillance, better data quality improves transfusion safety. Patient center hemovigilance, so we need to have more long-term follow-up, quality of life outcome, more shared decision, more holistic data that we want to bring out, and that probably will solve the, or obtain the objective. And finally, international data sharing. So eventually we want that the data which is coming out of various countries is more comparable, more analyzable, so WHO and other global organization can use this to develop policies for future. Finally, again, I would like to use this slide, which I did in the morning as well, that eventually a lot of our biological factors that we still don't consider will probably start making more differences and more influence on the outcome in the patient. And this is just initial work which is coming out of just the donor demography and outcome in a low birth weight child. But a lot of donor history, donor habits, donor disease history will start making more sense as we are getting into an area of big data and data informatics, and we may be able to know that which type. Now we just know a multiparous female plasma, it doesn't need to be used for transfusion, but we soon will be having a lot of other data to see which donor may be most optimal for which type of patient. Thank you.
Thank you so much, sir. Due to some traveling problem, Dr. Nishant sir is not able to join us. So I would like to thank all the participants and all our key speakers for their time and expertise. Thank you to all the organizing departments and the WHO SEARO for their unwavering support. And most importantly, I would like to thank all the delegates who joined us online today for their active participation in what drives the patient safety agenda forward. In this webinar, we have understood the importance of data on the basis of which we can analyze, we can plan our way forward, and therefore we request that if anybody needs a reporting format or a root cause analysis worksheet or any kind of template, they may feel free to contact us and we will share the templates with them. And also, as we close our third webinar of the webinar series today, we would also happily tell you that we are looking forward to welcome you all for the next session on the regional webinar series on root cause analysis and human factors for learning from patient safety incidents, which is scheduled for 21st of August 2026. So we look forward to having you all for our next webinar, and thank you all.